Good afternoon. Welcome to the virtual cardiology congress sponsored by Johns Hopkins University School of Medicine on Cardio Care Live. My name is Dr. Roger Blumenthal, and you are tuned in to a live session called Dyslipidemias and Residual Cardiovascular Risk, Biomarkers, Guidelines, and Treatment Approaches. I'm here with my colleagues, Drs. Chris Cannon and Mike Miller. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout each presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen. My friend Dr. Chris Cannon is Professor of Medicine at Harvard Medical School and Senior Physician in the Cardiovascular Division at Brigham and Women's Hospital in Boston. He's a Senior Investigator of the TIMI Study Group. My other good friend, Dr. Mike Miller, is Professor of Medicine in the Division of Cardiology and Professor of Epidemiology and Preventive Medicine at the University of Maryland School of Medicine. In addition, he's Director of the Center of Preventive Cardiology for the University of Maryland Medical System and Staff Physician at the Veterans Affairs Medical Center in Baltimore. Thank you very much. I'm very pleased that everyone can join us, and what I thought what we would try to do would be to go to the slides, and maybe Dale, with your help can get that first slide up there. So to just set the stage right here, we have some great data from the 2010 cholesterol treatment trialists meta-analysis that shows that whether a person has coronary heart disease, non-CHD vascular disease, or no prior vascular disease, that we see a relative risk reduction somewhere in that range of 20 to 25% with statin therapy. Chris, Mike, and I have been actively involved on the faculty at our institutions during the time that all these statin trials have come out from 1994 through 2008. The Jupiter study was the largest study and done centered at Chris's institution in Boston. Had 17,800 people, LDLs thought to be in the normal range, and hs-CRP greater than 2, randomized to rosuvastatin 20 or placebo for up to 5 years. And using a composite endpoint of cardiovascular death, MI, stroke, hospitalization for unstable angina, and revascularization, there was a relative risk reduction of nearly a half. Caveats are that the average age was about 66, and there was not a low CRP group, and we'll come back to that a little bit later on. Chris always lights up when we show the Prove It TIMI 22 study. This was his study that he presented. And this was a study of 4,100 patients with an ACS randomized to high dose of atorvastatin or pravastatin 40. And what we saw at the end of that trial was an event rate of about 26% in the pravastatin group, 22% in the atorvastatin group. And that's why at all of our institutions, when someone comes in with an acute coronary syndrome, we give potent statin therapy. In the more chronic coronary disease, in the TNT study, we were able to demonstrate that 80 milligrams of atorvastatin versus 10 milligrams of atorvastatin leads to a further reduction of events, about a 22% relative risk reduction. There wasn't an overall decrease in total mortality, but all cardiovascular endpoints did go down. And if you plot on the secondary prevention, the different studies, it looks pretty linear. So most of us have subscribed to the theory that lower is probably better. Chris is here, a Red Sox fan, and some of you may remember when the Red Sox won the World Series in 2004, they came from behind and beat those dreaded Yankees, and Pedro Martinez said that he was the Yankees' daddy. So we thought we'd put this in Chris's honor to say that statins are hyperlipidemia's daddy, and Pedro is finally remembered in the hearts of all Red Sox fans. We talk about side effects, but when you look at liver function tests, it seems that it's not that much different between control arm and statin, maybe 1.4% versus 1.1%, dose dependent, usually reversible. And in terms of myalgias, very similar. In terms of myositis, 0.9% versus 0.4%. And the most feared complication, rhabdomyolysis, according to this analysis of some 70,000 patients, about 0.2% versus 0.1%. We know that certain medications like gemfibrocil, cyclosporin, antifungal medicines, macrolide antibiotics, protease inhibitors can all raise the effective blood level of the statins. and small body frames, and I guess lots of grapefruit juice can also raise the blood level of statins. In terms of fibrates, the study on the left there is the Helsinki Heart Study. Mike, maybe I'll pose the first question to you. We see here on the left that the total event rate was 4.1% versus 2.7% in Helsinki. But if you just looked at those individuals with triglycerides greater than 200, it was 8% versus 3%. And on the right-hand side is the BIP study. Not much difference overall in all comers, but again, with triglycerides greater than 200, we see a 42% relative risk reduction. So, Mike, maybe you could start off about what the current thinking in your mind is about when to use a fibrate. Do you ever use gemfibrocil? And we'll get your thoughts.
Well, sure. I think these are good points, and I remember when I first got into the field, it was right before the Helsinki Heart Study came out. So that was very exciting because it came out back in the late 80s, and right after the same year that statins, lovastatin came on the market. But what has proven to be true in a lot of these studies is that in the placebo group, the folks that have the highest risk of events, as you pointed out, Roger, are those that have the high LDL and high triglyceride. In Helsinki, as I recall, to get in, you had to have a high non-HDL cholesterol. And so use of gemfibrocil, while it was highly touted and used into when I used it quite a lot in the 80s and into the 90s, the concern became the combination with statin therapy, especially with simvastatin therapy. So we then ultimately moved to fenofibrate as opposed to gemfibrocil, although good data with gemfibrocil, both from the VA HIT study as well as the Helsinki Heart Study.
And that VA HIT study is on the far right. I guess here in Baltimore, your VA was one of the centers, 22% versus 17%. So, Chris, let's go back to Prove It Timmy 22. What are the lessons that you try to teach the residents and fellows when you're attending in the CCU? And is there a particular statin that you use now, or do you just use the most potent statin when someone comes in with an ACS?
Well, I think we have moved to the class effect because there have been trials with multiple different agents. It's a very good point on what do we teach. Do we talk about LDL or statins or both? And that's a point that's coming into focus. I think traditionally we focus on reducing LDL. That's very likely the major mechanism of statins is lowering the LDL. The pleiotropic effects of anti-inflammatory effects are there, and how much they contribute, it's actually hard to tease out. And then how do we pick the intensity, I suppose, and the dose has been, I think, the topic. Should we drive it by monitoring the LDL and get that now below 70 is what many of us would aim for, or should we just use top dose of a strong statin and call it a day?
So those are all real good points. I want to encourage the audience to continue to send in questions.
And Roger, if I could just interject and point out, even before lovastatin came on the market, even before Chris's great Prove It trial and Forest, et cetera, there was the Lipid Research Clinic study. It was a non-statin, but did find that in patients that had FH, primary prevention study, that lowering with a bile acid resin did reduce cardiovascular events. Now, mortality, no, and not designed or not powered for mortality, but did suggest that lowering LDL in the pre-statin era did confer benefit.
Mike, the first question I'm going to pose to you from William Caput, he wanted to know what your thoughts are about, should we be measuring LDL particle size? Should we just look at the standard lipid profile, or should we consider measuring apolipoprotein B in our patients who have above average triglycerides? What's your approach?
Right. So my approach at the present time is to just keep it simple. And the reason I say that is that's what the clinical evidence currently has demonstrated. So we know that lowering use of certain therapies that favorably influence lipids, lipoproteins, especially LDL, does translate into reduced risk. Now, the Canadians and the Europeans have adopted ApoB and we'll have to see what ATP4 says, but I think whether we look at particle size versus ApoB, you still, I think, get a reasonable amount of information, especially what's evidence-based at the present time, would support perhaps maintaining some of these other measures for the intermediate risk patient, those in whom you're not sure to treat, but not due to a solid clinical foundation on evidence-based translation that lowering ApoB above and beyond other risk parameters adds to improved risk.
So Chris, the next question is actually addressed to you, and they want to know, and since you've done so much with HDL, in the primary prevention setting, someone with a Framingham risk score, let's say greater than 10%, or a Reynolds risk score greater than a 10% risk over the next 10 years. What about if the HDL is 60 or higher? Does that dissuade you from using statin therapy if they're in that intermediate risk category? And how important now is HDL in your thought processes for the primary prevention?
So great question. Answer, no, it's completely independent. And it's something that came up actually immediately after Prove-It, as people said, well, what about the high HDL? Does that cancel out? My mother is one her HDL is 105.
Wow.
And so she asked me, do I need to bother to treat my LDL that's 165? I said, yeah, that's a little high. So the benefit has been seen in various trials regardless of the HDL, be it high or low, but definitely do see a benefit. I've actually also struggled with the ApoB and the particle size issue, and I think in general, just keeping it simple, figuring out what the Framingham risk is sort of step one. But there are patients that you kind of get worried about, and there's sort of 5% or so where you think, the LDL's not so bad, and yet they're looking. I have one guy with very high triglycerides, and we're trying to sort through, and there we started doing the ApoB and finding it much higher than we anticipated, found interestingly that pioglitazone was something that ended up helping reduce. But so I think it's found its way in a small percentage of patients.
I would agree. Yeah, we use it the same way in those kind of, patients on the fence. Should I treat? Should I not treat? Should I explore a little bit more with high risk?
I think we have a question from someone I think you know named Miles Miller. I wanted to ask you about your thoughts on the Accord lipid study. And we have a slide up here about 5,500 diabetic patients, all on statin therapy. It was typically 20 to 40 milligrams of Simva. They were randomized fenofibrate or placebo for about 5 years. And on the background of statin therapy, the fibrate did not reduce events significantly. That p-value was 0.32. The CVD event rate per year was 2.4% in placebo, 2.2% in the fenofibrate group. But Miles was wondering what your thoughts were on that of the analysis, post hoc analysis about triglycerides greater than 200. Miles wants to know, do you routinely give fenofibrate in a diabetic if their triglycerides are high?
We tend to use fenofibrate in that group of patients, and in fact, it's, as you point out, a nice paper that came out. I think Frank Sachs might have been the primary author. Really looked at not only Accord but some of the other trials that explored those individuals who benefited most from fibrate therapy, and it was the subgroup of patients that tended to have high triglycerides, generally above 200, give or take, low HDL, and they tended to have benefit, whereas others receiving fibrates had no evidence of benefit. So if you're going to use fibrates, and we do, in diabetic patients who have elevated triglycerides, elevated non-HDL, then that would be the group who I think would get the most bang for the buck.
Let me ask, is it high triglycerides alone or the combination with low HDL that the fibrates are really good for?
Interestingly enough, in Accord, when they looked at just triglycerides alone, they didn't seem to get as much of that benefit. And again, it trended. It was not, I believe it was a 0.057, but it was the high TG, low HDL. That tend, and most of the patients that we see with vascular risk tend to have that, being that quandary, and often will have some degree of elevated LDL.
Now, and this is a great question. Now, what about for just high triglycerides? Because there's a fair number of people that wander in with, 3, 4, 500, is fibrates the first go-to, or fish oil, or?
Right, so if it's above 500, then I think you have a choice. I think fibrates, and often we'll use a combination of fibrates and omega-3, I think is a reasonable combination. We can add niacin as well. If there's no evidence that there is vascular risk, you're treating more to reduce the risk of pancreatitis, even though there's no data to show that treatment reduces the risk, but still we're concerned enough to treat. If the TG is below 500, or if we're outside of the risk of pancreatitis and we're concerned about vascular risk, then it's always statin first, and then we might add the fibrate or omega-3. And the jury is out on this, and there's a clinical trial that's underway right now called Reduce It. And it's testing the hypothesis that in patients that have some degree of triglyceride elevation and vascular disease, that on top of standard of care, the addition of omega-3 might, and this is an EPA compound, might reduce risk compared to standard of care alone. So that's underway right now.
So you think that the EPA component is better than the DHA component in terms of lowering risk? Is that the thought of that Reduce It trial, since it's pure EPA? Is that correct?
Well, I don't think we know. I think the sponsor
is hoping that.
Well, the sponsor is pure EPA.
Right.
There are other sponsors that had a combination, but this is the sponsor that is doing the study.
Sure. Chris, this next question from Dr. Abbas Blusamaz for you, and actually also for Deepak Bhatt, but Deepak's not here, so we're going to address this one to you. It said, the majority of people using statins are using beta blockers at the same time. Does that negatively affect their lipid profile? And especially the recent paper that I guess Deepak was an author on, saying that in the REACH registry, long-term use of beta blockade didn't seem to further reduce events. So two parts, I guess, Chris. One about your thoughts about beta blockers long-term, especially in the people with low HDL, and do you think everybody reflexively, when they leave the hospital now, if they've been revascularized, need to be in a beta blocker?
So good question. I was part of the same observational analysis and want to add caution that it was simply an analysis of a registry. For the lipid profile, I guess it may impact it adversely, but we have to use beta blockers post-MI and do. I think you can override whatever adverse effects you'd have, but it's an interesting thing. This has come up now with statins causing diabetes, but we know that thiazides and would see this across multiple different classes of drugs. The analysis from REACH looked at patients with stable coronary disease with 4-year follow-up and compared those who'd gotten beta blockers versus not, and didn't see much of a difference in outcome, did see lower event rates in those who were post-MI, and less so in those with just documented coronary disease. This was just an observation, and so not a randomized trial, and I think raised the idea that maybe if someone's very stable in coronary disease that you might not need them. I think clinically I would take that information and sort of say that if there were side effects or other problems and things that it might not be so critical in a otherwise stable patient, but certainly continuing it for post-MI long-term, I do, and all guidelines say to, and using it for angina.
So, Mike, Dr. Lawrence Baruch wanted to know if you knew what the approximate triglyceride cutoff was and Reduce It, and if the second part was that if indeed the data with fenofibrate isn't as promising, what about extended release niacin as a second add-on agent to reduce residual risk? What do you recommend?
Sure. So with respect to reduce it, the cutoff is a triglyceride of about 150, although we appreciate, I'm on the steering committee for the Reduce It study, but we appreciate, and Dr. Bott is head of that, Reduce It. But we appreciate the fact that triglycerides above 200 seems to be a level above which risk does rise. And so it seems many of us believe that if we are going to see positive results in the study, we would like to see a greater proportion of the patients and Reduce It having a TG somewhere above 200.
Yeah. See. Well, you analyzed also Prove It, and above 150 was worse than below 150. So
that's right. So above 150 was associated with reduced, a less favorable outcome.
Yep.
For sure, reduced risk.
So I guess the second part of the question dealt with what your thoughts might be about niacin, and we have the design here, the AIM-HIGH trial up where we have simvastatin versus simvastatin plus niacin, and we had all this great surrogate endpoint data suggesting that we could decrease carotid intramural thickness. You were a co-author on the Arbiter 6 HALT study. But then, lo and behold, something happened. We had this tremendous explosion, and we just didn't see the benefits there. So tell us a little bit about what your thoughts are about niacin in this day and age, and maybe give us a preview, Mike, of what we should expect from HPS2 Thrive.
Right. So I think the main take-home message of AIM-HIGH specifically, and in the statin era, generally, is the fact that we're treating our patients quite well. And in AIM-HIGH, baseline LDL levels were unprecedented because they were receiving statin or ezetimibe. So the combination there kind of brought LDL baseline down to roughly approximately 70. Mm-hmm. So now you're competing with an LDL of 70 across the board with the addition of niacin. Now we do know that niacin at higher doses does also lower LDL. And so the difference between AIM-HIGH, which was disappointing and may have been related to the fact that when you drive LDL levels down, even with a little bit of niacin added to it to raise HDL, although the HDL decreases were not that great either, because of the fact that the placebo group also received crystalline niacin up to 200 milligrams a day, and that boosted HDL far more than we thought. About 9.8%. So the differential between 30 and close to 10 was at 20%. So that also may have minimized or attenuated the differences otherwise seen between the groups. We're not going to see that in HPS2 Thrive because they're not going to control, they haven't controlled for LDL so that the group that on the placebo will receive standard of care, but they're not going to beef up their statin therapy, and they're not using other LDL lowering therapies. So we'll be able to get a better feel for niacin on its own on top of standard of care. And so if I was a betting man, based on all the other niacin studies that we've seen, I would like to believe that it will be a positive study. This is HPS2 Thrive.
But didn't you put a lot of money on the Ravens over the Steelers last week? And, you're betting
Roger, I am broke. That's why I'm here today.
So, Kristen, the next question is from a friend of mine in town, Dr. John Lavin, and he knew you've written this very nice review in JACC, and he wanted to about statins, and he wanted you to discuss what's known about memory effects, executive function effects in statins, and that he sees a number of patients absolutely convinced that that their prescribed statins have caused problems. So maybe you could give us your review of the literature and some of what you published in JACC.
Sure. About a year ago, the FDA put out a new warning saying that they had received reports of cognitive changes and memory loss. And they made reference to the fact that these were simply the reports of individual cases. It sounds like perhaps like some of the patients you've talked to. But they also said, but seemed to ignore, the randomized trial data. So there had been a thought, and a prospective part of the PROSPER trial was to see whether statins could improve cognitive function by preventing stroke and vascular changes. So they did 4 different, very detailed, validated cognitive function tests over time. It was a moderate size trial, I think I want to say 4,000 or 5,000, just in the elderly. They saw absolutely no difference of pravastatin versus placebo on any of the measures at any time point. Then the heart protection study did a single cognitive function test at the end in 20,000 patients, and absolutely no difference whatsoever. So in the large randomized assessment, it was hoped you'd see an improvement. They saw no difference at all. The FDA's warning is based on individuals saying my memory's not so great, and that happens for various reasons in different patients. But so far, there's really been nothing to tag that to statins. Unfortunately, this warning has made a lot of people stop statins just for fear of this. And so, unfortunately, that may be leading to more cardiovascular events from this, warning that the FDA has put out.
Mike, I guess a question for you would be, if you have a patient who says, I have muscle aches, I have soreness, my memory isn't as good, what's your next step? Do you give them a 2-week holiday and re-challenge them? Do you go to a different statin, or do you have a sort of a recommendation for the many clinicians out there about how you would approach someone who is pretty sure they have some sort of side effect?
All right, so the first thing is always believe your patient.
Okay.
The customer's always right.
Okay.
And clearly we've had enough experience over the years to appreciate that some patients will have various complaints. And so if they say they don't feel well, they have headaches, their concentration is off, etc., I take them at their word. I stop the statin if I believe that's what the cause is, and give them a holiday. I generally give them at least a week holiday, have them 1 to 2 weeks, have them let us know, contact me back and let us know how they are feeling. And then I can decide on what I would want to do. And if they have vascular disease and I think I would want to try them on a statin, I might try a low dose of another statin. And I will often employ, I'll start off at a statin at maybe 1 to twice a week, off-label, and then move on to every other day and see how they do. And quite frankly, I have quite a few patients who do very well on a regimen of Monday, Wednesday, Friday. And that's it. And they get reasonably good results. They get 30% LDL lowering with some of the more potent statins.
I agree. I think adding into that, I explain to the patient that let's together do an experiment. And if you're feeling muscle aches, whatever, it might be the statin. It could just be that. So what we'll do is stop. I often do a month, or if it's late, and then tell the patient, you can see if you feel better, and then we'll do the experiment. We'll start it back up again and see if the things come back. If it didn't go away, obviously it wasn't the statin then, and get them to be the arbiter of their own symptoms. And this definitely happens. Muscle aches, it happens a good bit. Parents and brother have been on and off of rosuvastatin, back onto pravastatin, although my mom is off of everything for the moment. But
it happens a lot more commonly in the real world, for sure, than it does in clinical trials, where oftentimes
there's a run-in period.
And the run-in period takes them out.
So, Mike, the next question from Dr. Baruch is, how do you use lipoprotein(a), especially if you have good LDLs? Do you ever use a high Lp(a) as a tiebreaker? And if it is high, do you just push the LDL down lower? Or do you automatically add niacin?
Right. So I generally have not done Lp(a)s on a routine basis for a patient coming in. I will do it in patients that come in with strong family history of heart disease. I will also do it in patients that come to my attention that have some degree of LDL elevation. And we've encountered some patients with Lp(a) levels in the 1 to 200 range, often in association with very striking premature disease. And in those cases, I will put them on a combination of statin. I'll use niacin therapy, realizing that we're going to drive down Lp(a) levels perhaps 20, 30, 40%, not normalize it, and still we don't have outcome data to show that treating them in this manner reduces their overall risk. We have some of Greg Brown's data from the FAT study showing that if you lower LDL level with statins, you tend to reduce the elevated risk associated with high Lp(a), but beyond that, it really hasn't been tested in a manner that I think would behold some of us in the field.
So, Chris, a question sent in by two people. They're both from Boston. One is Dr. Soren Skafsky, and another is someone you know from LinkedIn named Dr. Giselle Bunchton. And they both want to know, what are your thoughts about starting statins in pre-diabetics? Do you fear that the statin may raise the blood sugar some? And if the sugar does go from 110 to 130, would you change the statin?
Very good question. I think for starting...
Giselle says thank you very much for that.
Well, might have to get them in for an actual office visit, none of this virtual stuff. The first step, I suppose, in a pre-diabetic is sorting out risk. And so this is the primary prevention where doing the Framingham risk score will be helpful. Mm-hmm. Sometimes the risk will be low, say less than 5%, and that's the group where lifestyle intervention and weight loss in particular could go after the pre-diabetes and potentially the lipid abnormalities. So starting there, I think one almost always starts. You don't want to quickly just throw a pill at someone who really does need lifestyle intervention.
Now, if you have someone who has vascular disease and their sugars go from, say, 115 to 130, would you ever change to a less potent statin?
So I've not encountered this clinically. It's come out, first seen in Jupiter with 17,000 patients. And on an individual patient, I have to say I haven't come across someone that suddenly looks like they converted to diabetes from being metabolic syndrome type. I suppose it's certainly something to think about, but the intensity does matter. So that a colleague did a meta-analysis of the high dose versus regular dose, and there is a higher incidence of diabetes and worse hemoglobin A1C with the high dose versus lower dose. So that idea is a reasonable one of lowering the dose while maintaining the statin.
So, Mike, Dr. Carl Adler had a couple questions. One is, it brings up the point that niacin tends to raise blood sugar just as statins and thiazides do. But he also wanted to get your opinion on the chart that we have up there that basically says that right now our guidelines say we want to get to an LDL of less than 100, and we have an optional target of less than 70. But what is your prediction for ATP4? Will we still be sort of required in our high-risk patients to try to add on a second agent to get to 70, or do you think just using a potent statin by itself is good enough?
Right. So I'm not on the committee, but
you did go out for drinks at AHA with a lot of the committee members, right? And maybe you got some insight.
Except I can't remember now. It's that memory from taking the statin.
Oh, okay. Thank you.
But I think, in truth, the task of committee members on national guidelines, and it's not only for lipids, it's for blood pressure, and I'm going to say probably for diabetes and other aspects of cardiovascular disease risk and disease itself, is really to try to use the best evidence available. And the best evidence at the present time would support therapy over cut points because of the designation to which these clinical trials were designed. It was designed to test a more potent statin versus a less potent statin. It wasn't designed to look at a specific cut point. Now, it turns out, IMPROVE-IT, for example, that an LDL less than 70 was better than an LDL of about 100. And we'll get more data perhaps within the next year or two on IMPROVE-IT, which I believe, Chris, you're spearheading. So I think we'll have more data. And that Improve It is truly designed to look at this question of cut points, albeit with combination versus single agent. So at the present time, I don't think we have a whole lot of compelling data to support cut points. Now, if you go back to ATP2, back in the 90s, they did use the number of 100, and the number of 100 was designed based on trials that showed if your LDL was less than 100, you had reduced arteriographic progression. So those were the days of arteriographic studies, not clinical outcome studies. So my guess here is that for the upcoming guidelines, the focus will be on using therapies that have been shown to be of benefit rather than cut points.
So Chris, let me ask you as a follow-up. You have a patient starts off with an LDL of say 170, and there's one of those patients who, because of muscle aches, you're only able to get them on Atorva or Residual maybe 3 days a week, and their LDL, the best you can do is 120. Do you think, since we don't have the Improve It data, would you empirically think about adding ezetimibe or niacin or fenofibrate, or the fact that you've pushed the statin as best you can, is that satisfactory?
Well, a lot of it depends on the risk. So if there's known vascular disease, I think then the patient has the disease, and trying to get as low as you can safely would be the objective. And as noted, lowering LDL has been seen in with the bile acid, the ileal bypass, and then the various statin things, to some extent, perhaps even the niacin versus placebo study has a big LDL component to it. So there, I think, aiming to get into double-digit LDLs is always better than triple digits, and trying to maneuver. Now, it's not ready for prime time, but the PCSK9 inhibitors are going to be a way to get everybody down to 30 or 40, which is really exciting, I think, for especially people who have bad and real muscle aches and and are statin intolerant, but for everybody.
But before we get to the PCSK9, a new one here from Dr. Keyshawn Johnson, Dr. Chris Berman, asking you, they say, Dr. Cannon, you've been running this Improve It study for a long time. Will you keep running it until the drug goes off patent? And then they say, sooner or later we need to end this study. And then Chris Berman and Keyshawn Johnson then put this comment in, come on, man, we got to end this study and get the answer, does it work or not?
Okay.
Can you give us an update?
Well, I'm all for it. So the current status is it had a DSMB review with 75% of the events. We will have 18,000 patients, and in order to detect what ezetimibe could produce based on the CTT, a 9.375% reduction in risk, we needed 5,250 events.
Okay.
Now, of course, we had 1,000 events in Prove It, so this is 5 times the number of events in this study. So the DSMB is due to review again this coming March, and then our projections are that for April 2014, we would have the 5,250 events. So depending on what the DSMB tells us, or in 2014, we'll finally get to the end. Dr. Grunwald often jokes as to which of his grandkids will be presenting the results, but we're all with you that we'd like to get the answer as soon as possible. The good side of it is if the event rates are low in the trial, the therapy may be working, because event rates are low, but we agree it was supposed to have been over many years ago.
Well, this next slide, gentlemen, just to review sort of our timeline, we had ATP3 in 2001, we had the update with the white paper in 2004, we had Canadian guidelines that were the first in 2009, and European guidelines in 2011. Hard to know. Do you think we'll get ATP4 in a month, 6 months? What are your thoughts, Michael, and what changes do you think we might see?
Well, I think ATP4 will be coming out within the next 6 months. I think that's fair to say. And what do I think? I think if, in fact, the task for the guideline writers is to really hone in on the proven aspects, then it should be relatively small, evidence-based. So, I don't anticipate that the document is going to be super large. Now, if they're able to voice their own opinions, which has traditionally been set the tone for previous guidelines on top of what was available at the time, then it'll be a much larger document. Having said that, I'm going to go with the notion that this will be predominantly evidence-based, and then the rationale will be to use therapies that are proven to reduce risk, and perhaps, as Chris pointed out, using potent statins, for example, to have a significant impact on lowering LDL cholesterol, based again on the data. As far as other values to look at, we've had Framingham risk. I would like to see, I've made the case to use lifetime risk, because I think that's a much better valid measure than just 10-year risk. Especially, we see so many middle-aged individuals, and if you're 40 or 50-year risk over the 10 years is obviously quite low unless you have all the risk factors. But I think lifetime risk really gets at it, and that is a really important message that the physicians can take to their patients if they could use lifetime risk. So I would like to see that in play.
Yeah, I agree. I think that the Framingham is very helpful for older patients, but all the 40-year-olds who want to do something and avoid getting into trouble, there you need a broader perspective. Okay. It looks like they're doing a really good job of trying to be evidence-based, which is great, but I'd hope that a new mechanism could come up with for keeping pace a little bit better. So for example, if and when IMPROVE-IT ever does finish, that obviously won't be in ATP4, right, but it would be a trial that could have updates. So the other guidelines have been able to do sort of planned, more frequent updates, and hopefully that will be the case here as well. Which
was an ATP3, where your IMPROVE-IT study basically got the option of an LDL less than 70.
Yeah.
So Chris, the three of us were co-authors with a group of fellows here from Hopkins, and a nice waiting for ATP4, anticipating the new guidelines and what we thought should be in there. And one of the points that was made was highlighted on this slide here about the European guidelines prescribe a statin up to the highest recommended dose or highest tolerable dose to reach the target level. And it sounds like we all agree that that's what we're going to try to do, use a potent statin, see how far we go. But is it your thought in secondary prevention, where they already have the disease, that you have a much lower threshold of trying to maybe add in a second agent if your LDL is still above 70? Is that what you try to do clinically right now? Let's say you use a high dose of Atorva or Residual, their LDL is 90, 95. What do you do when you're the CCU attending or seeing patients in the outpatient center? Do you routinely add a second agent if they push lifestyle as far as they can go?
I think yes. I mean, certainly if in the secondary prevention mode, trying to aim less than 70 is certainly a goal that I have. So Atorva 80 now is inexpensive and becomes a nice base. And if the LDL is in fact 95, that's pretty darn high. And so trying to get that down further, I think would be appropriate.
So I wanted to shift gears to what came out and presented by Jennifer Robinson and Neil Stone at the last AHA, where they were sort of looking at the latest cholesterol treatment trial, this collaboration. And they sort of focused on this 5 to 10% 5-year major CVD risk. And what they told us is that this major CVD risk includes revascularization. So if indeed you just look at heart attack and stroke risk, then that's about a 5 to 10% 10-year risk. And they show here that in that subgroup, Mike, in that 5 to 10% range, it looks like it's a significantly decreased risk of total mortality as well as vascular events. And I wanted to ask you, right now when you see your patients, are you looking at the 2008 Framingham score that includes heart attack, stroke, heart failure, and PAD, or are you using the ATP3 risk score now? And what do you recommend for our audience to do?
I've been generally using more of the scores that evaluate all of vascular risk. So that would include PAD and even CKD. I think CKD was left out of ATP3, but should be part of the overall, if we're going to continue to have risk equivalence as we did for the diabetics, I think there's good data to support CKD as well. So any evidence of known vascular disease, whether it's PAD or cerebral disease, but also incorporate CKD is what I try to do. I actually consider that a risk equivalent in my practice.
Yeah.
So Chris, this was another slide that was shown at AHA, where they tried to look at if you include the development of diabetes, myositis, any other hazards such as potentially a slight increased risk in intracerebral hemorrhage, that your number needed to harm is lower than if you have a high intensity statin versus a moderate intensity statin. And it seems to be if you're in that 5 to 10% range, the number needed to treat is much lower than the number needed to harm. What do you think? Is it fair to sort of say that we're going to be giving a lot more statins to people if indeed we're looking at heart attack and stroke risk less than 10%? You mentioned about maybe starting people earlier in their 40s if they have risk factors. What do you predict that we'll see in guidelines that'll be upcoming?
Well, all this is so complicated that I go, if you have vascular disease, coronary, peripheral, etc., or diabetes, it should be high-dose statin, LDL less than 70, and other risk factors, getting the LDL below 100 on a statin. That's my approach. And then the statin intolerant, you have to switch to the few times a week and stuff like that. And then, again, I've not seen the actual diabetes risk thing in an individual patient. So trying to reduce their risk, and the benefits are so huge that I don't know why everyone complains about it. But somehow people don't want to take yes for an answer. We have a great therapy, and it's now generic. It doesn't cost any money. And hopefully, getting this out to patients will be helpful. The polypill concept is to try and take people with whatever the risk and get them some therapies, including lipid lowering, and I just hope it'll happen.
So, Mike, we're nearing the end, but this also came from our paper in the American Journal of Cardiology, where we sort of showed that clearly those people with vascular disease, high risk, will use a potent statin. Those people with very low risk and no traditional risk factors will just focus in on lifestyle. And then we have that people with the high lifetime risk where we want to have that discussion with the patient. Dr. Yostos writes in wondering about, in that high lifetime risk, individuals who have those higher triglyceride levels, maybe small dense LDL, how does that sway you one way or another? Do you give lifestyle a certain period of time to sort of see if they improve the triglycerides? And if so, how long? And the final point he has here is any particular diets better than others to try to lower triglycerides?
Right, so for triglycerides, and in the AHA statement, the idea here was the notion that you could really have an impact on lowering triglycerides upwards of 40-50% with lifestyle measures, and they include lowering total caloric intake, number one. So we want to induce weight loss. 5 to 10% weight loss can confer up to a 20% TG lowering. Want to reduce, obviously, saturated fat, eliminate trans fats if possible, and and reduce simple sugars. Mm-hmm. So go to more of a, as we like to call it, a Mediterranean diet, if you will. Get out, exercise, walk briskly. Walking at least 3 miles per hour, defined as walking briskly, can also help to potentiate that TG lowering effect. So between the exercise effects and diet and weight loss, we could have a really nice effect. I would do it for 3 to 6 months. Of course, it depends on what your baseline triglyceride level is and what other risk factors may be associated with it.
So Chris, we have this quote up here from Dostoevsky that says a second half of a man, or we could say a woman's life, is made up of nothing but the habits he or she has acquired during the first half. Do you foresee that the ACC will be trying to do more from a lifestyle point of view? And maybe you could just briefly tell us a little bit about CardioSource, and are there some good resources there that we might find about better dietary habits?
Well, it's interesting having thought about being midlife that I actually would challenge that to say, I want to try and do some new things and reinvent oneself. And I think if there has been disease building up, to go after more exercises. You've noted very practical recommendations. That can make a huge difference, and people can get in shape, and there's no reason to sort of write yourself off.
Okay.
On Joanne Foodie, I think, is coming. She runs our wellness, has lots of stuff on cardiosmart.org for patients, and the AHA, and everyone has good materials, and just do it,
You heard the Nike phrase right here, just do it. Well, folks, as the hour's flown by, it's been great being with two of my closest friends, Dr. Mike Miller and Dr. Chris Cannon. I want to remind all of you to fill out your evaluation forms. I'd like to thank Abbott, Amarin, Boehringer Ingelheim, Daiichi Sankyo, Lilly, St. Jude, Giselle Bundin, all from their support for this important educational series. Remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Roger Blumenthal. Thank you very much for joining us here at CardioCare Live.